The full-fledged implementation of this notion is also not possible under the war conditions. And the next one is the justice. Indeed, we can justly provide medical assistance to males, females, and to different races, different age groups. And again, this problem with the aid provision, we don't have this problem at all when it comes to justice. Starting with the basic notions, we cannot guarantee the qualitative medical aid provision under the war conditions. When one talks about the army, we are facing 6 problematic criteria. Why they are problematic? Because the notion of military medicine or tactical medicine, first one, there is not even medicine, but tactical or military, meaning that the priority is the battle order fulfillment. Medicine goes to the second stage. Next one is the hierarchy. In any case, we start to fulfill any task, and if we will be in secure environment and we'll receive the order for this. Next one is the deficit of human capital. We provide help to those who is categorically not capable of fulfilling his or her battle mission, or until we have the power to do that, because there is nobody to supersede us with. Next one is the uncertainty. We indeed have no idea how much days or hours we will be working 24/7 without the conditions of the possible rotation of between medical personnel and military personnel. And when one talks about normal conditions, we talk that patient with some kind of disease or with some kind of wound have to recover completely. The full recovery is when a person physically and psychologically, mentally, socially is capable of fulfilling by him or her some precise functions that he or she has been doing before that. When we talk about military medicine, we do not recover as a human being completely. We are talking that this person has to go back to ranks. It either has to do to fulfill the same function with that condition that the person has, or to come back to the ranks, or the ones that this person had been doing before that. And while exhausted earlier, then a person has been exhausted before that. Here I wrote down that one has to take into account age, stress, and primarily unacceptable people who are there in the system. However, you can give me a good counterfact that in stress, not only military personnel lives, even civilians do live under the stress conditions. I completely agree with that, but the conditions of stress are completely different. And the age category of military servicemen and the middle age of the middle average serviceman is going up, and with each year the middle average age goes higher. Unfortunately, the tasks and the conditions for the fulfillment of the battle orders and those fulfilled as a battlefield do not meet the growth of the age category of those people who are in the army. And the last one is a primary unacceptable person for fulfilling the combat orders. Let me explain to my colleagues from abroad what I mean by that. At the beginning of the war, we have only health people who are in the army, those who have power, those who have capacities, and who is ready for military service. For the second year of war, there are partially healthy people and partially those who remained to continue their battle mission. Starting from the 4th year and on, there are only those who is capable of being in the combat. Not always. These are healthy people. These are those who are capable and who wants to, and that's additional load on the system of medical protection system. Doesn't matter how we don't want to accept this, but this also has to do with the increase of chronic diseases in the Kherson, as well as the increase of the possibility of traumatization, and also this is at the expense of the limitation of some physical capacities. The speed of running, the speed of movement, this is a higher risks of receiving the wounds on the battlefield. When we talk about quality as it is, we are based on 3 main definitions in order to implement this in practice. First one, education, teamwork, and the third one is the learn by mistakes. When it comes to all these 3 definitions, I'd like to bring them all from medical field to battlefield. In Ukraine, there is no professional tactical medic education at all. Perhaps that's quite a very robust thing to announce. Yes, we have Ukrainian military and civilian academy, but when we talk about professional military education for doctors and medical workers, we don't have it. Education should meet that very conditions we are in right now. It cannot meet the conditions of the year 2022. It cannot meet the conditions of the 2014. It should learn the medics to survive under the drones. It should learn and teach the medics not only to provide the first aid under aviation bombs, but also to be able to protect themselves. That is why when it comes to professional medical education, we don't have it. What is the way out of it, since we continue to live in these same conditions? The easiest is before teaching people inside the unit. When they are mobilized, they go through the basic training, and then they go through additional training, acclimatization, adaptation. We can call it different words. But these are those things that we additionally do inside the unit. Obviously, this all has its own risks because what I have mentioned about the absence of standardization, we cannot guarantee that in every unit there will be equal level of training. We cannot training because it will be definitely different. And whether this is the correct way out of the situation, that, well, this leaves the question open. I don't know whether we have the representative of MOH of Ukraine here. Do we? This question remains open, and all in all, it requires deeper study because without education, there is no implementation of all those things that we work with when we talk about a patient. Next one is the teamwork. From a possibility of impossibility of not having the teamwork up to being documented in the unit. When a person comes to the service in the precise brigade, it goes through some precise training. It can be different training centers, and conditionally, one brigade that consists of anesthesiologist, trauma surgeon, anesthesiologist, medical nurse, or medical brother, it can be going through education in different training centers. In order to synchronize their job and work, we additionally have to have the additional training to them, to all the brigades that are there in the working in a precise military unit. This all makes us to create another more type of adaptation in addition to training after they enter the unit and preparation of them to fulfill their combat mission. There is a risk. This is, again, the local standardization on the level of Army Corps or brigade. How can this threaten us? Well, that there are different levels of training, different ways of training, and this all come back to the quality control. We don't have anything to basically assess, and this all leads us to the dead end when within one region there are two different brigades with a lot different ways of medical aid provision. Is this okay? Well, all in all, if a patient is being provided medical aid qualitatively, I would like to say, but we don't know if the patient is if it doesn't. And we are slowly but surely coming to the learn by mistakes approach. Very much relevant these days is the lessons learned approach. We do not learn, unfortunately. Things that we can do is identify a lesson. Lessons learned is when we have processed it, get familiarized with this, and fulfill it in the further lives, the lesson that we identified. In our case, we indeed are identifying it in a very good way. We find the spots where I did something wrong. We understood the ways how it used to work before, but we cannot adjust our work to the extent to not to do the same mistakes. This has to do with many other things, not only in military sphere, but also in civilian sphere too. Where is the problem here? The problem is that we are afraid to talk about the truth, about the made mistake, and it is much easier to talk about successes, obviously. Why? Because when everyone survives, to say that there is a problem is not that much easier. We all survive, let us move on. If somebody dies, there is a situation when it is already complicated. Let us not touch this topic at all. Let us move on. And the third one, well, I will not tell about my colleagues that my colleague made a mistake, obviously, because colleague will not tell it. I will not tell it about my colleague, and we continue, just move on. Why is this all happening? Since we talked about the punishment fear in the modern. This punishment fear comes from civilian sphere into medical sphere, and it doesn't have any differences. Military doctors are the same civilian doctors who put on the military uniform. We in the armed force of Ukraine who have graduated as a special educational establishment, who were studying only military medicine, with each year, the percentage of these people goes down and down from 10% and less. All the other doctors and medical servicemen, these are the ex-civilian citizens who either signed a contract or were mobilized and joined the armed forces. So what is the possible way out of all this? Very often, one tells that the study and the learn by mistakes means that we have to teach doctors to acknowledge their mistakes. I do not agree with that, because primarily we have to teach commanders and leaders that a mistake of a doctor, of a medic, is not the final sin of these military servicemen. The mistake of a medic is a normal history that should be processed, where a problem should be identified. And very often when we talk medic mistake, we mean that this precise person made this precise mistake. But we do not take into account the factors when a mistake can be done based on wrong lab estimations or incorrect assessment from diagnostics specialist, the inappropriate data at the very entrance stage, or those unchecked data, and so on. Meaning that the question of the error of some precise specialist very much leads to a complex mistake. So not work through algorithm of actions, the untrained previous stage of medical aid provision. And we are talking here about a situation, about a problem when it is already visible. But when everything is happening and is done well, then we can very often forget about it. And one has to work with this. One has to work with this, and primarily with the commanders who will be encouraging to process the situation, to study the situation, not looking out for those guilty ones, but looking out for the problems that one has to solve. Because those guilty ones will not be able to resurrect the dead. But the people being trained will be able to save the situation with people being trained. What are the risks from teaching and from learn by mistakes? Today in the armed forces, due to the reform of the armed force of Ukraine, there are army corps created. In each army corps, automatically there is a group of the experience implementation group. And also it has to do with the medical teams. These teams have to do the outer consultations, advisors, assemble data, analyze them, and as a result to issue out the proposals to the commanders about what to do next. What is at risk in this regards? First one, if we didn't do this kind of training of the commanders, then commanders do not understand what one should do and why this should be done. We also can have formalization when we provide not the correct data to the commander, meaning that everything is working properly, everything okay, there is no need to improve anything, everyone is at a boy. Second moment is the puts the emphasis not on the problem, but on the lookout for the guilty ones. And we come back to the previous topic. Until all the people who do the decision making are trained, until then, the process will not move on. And the third one is the incorrect data. And what I mean by that, however, when we talk about the incorrect data, it's mostly about changes, the superstitions, or not telling the whole truth about those things that happened. If it is possible to, on this example, I'd like to explain that all in all, the problem of tuberculosis in civilian and military field is not solved. A big amount of people with the covered form of tuberculosis or uncovered form of tuberculosis come to the armed forces. We do the initial testing while a person comes to a precise brigade. If the commander is not trained, he takes this problem as a problem that so the military commission that was before the trained center. They don't have to do the this scene. So the problem is not only on the strategic level, because on the level of the Ministry of Defense, there should be changed the approaches towards. So in order not to have the overload of the military system, this can be done on the civilian level, right? But when this situation happens on the operational level, we have to do the entrance testing. If we do not talk about the information that there is a fighter with a tuberculosis, the amount of contact persons who have been in contact with him increases, and this all starts to roll as a scene in the desert. And at the end of the day, the amount of people with disease will be increasing up to that moment that later on we will not be able to solve by ourselves. That is why it's either the truth or the absence of the result. The third is not given one. So what should one do in this regards? You can see this very fallen bridge. Very often things fall in our case, and they fall as some kind of when some kind of good project can be, and can be fallen apart, but something should be done. And all in all, we cannot withstand then.
When bridges collapse, the military are trying to have something simple to help them cross the river. These are very simple structures next to a bridge or in another place. But the most important thing is to understand that the destroyed bridge is not the end. It's a possibility to change an approach to the way we provide assistance if we want to do it, if we want to provide it. So then I have this rhetorical question for everyone. What is the quality in the military forces if the priority is returning to duty, but we don't have any other priority? We need to treat a person so that they can do their combat mission, but that does not guarantee the full recovery of mental, physical, social health. We are facing a great challenge in the fourth year of the war. How do we stand firm? How can we persevere? And how can we support doctors who have been working for 4 years, can still remain focused on patients, can still treat people in a safe way, so that they are able to do their utmost to improve their knowledge, so that a patient that returns to duty can return to that duty. Thank you so much for your attention. I think it's time for your questions. Welcome. Could you please describe the training options for military doctors or civilians who join the military? What kind of training they have? How long does it last? And what do you think? Is it enough? Is it not enough? And how would you change their training? Thank you so much, Juliana. As of today, the doctors who join the military undergo a classic training course for doctors. This is 4 years of university, then a couple of years of internships based on their specialty. After that, the doctors can undergo 2 months courses in Ukrainian Military Medical Academy, or they may skip that if they are officers or they are junior lieutenant of the Armed Forces of Ukraine. In that second case, they join the military directly. So when we are speaking about, when we say that they are not fit, not ready, when I'm speaking about the necessary training that's not there, let's say we're speaking about the surgeon who's had full medical education, and let's say he's had 2 years of practical experience. So he's entering the military for role 2 or role 3 if that's the hospital, and he has to have all the skills of damage control surgery, damage control resuscitation. He should be able to have all the skills of tactical medicine, because tactical medicine is about any location where the emergency can occur. That person has to have all the skills to protect himself and others. He needs to understand what drones are, what kind of attack can happen, because that's about his safety and the possibility for him to provide support. So if you're speaking about trauma surgeon, he needs to have all the necessary knowledge of all the sub branches of surgery. We don't have trauma surgery courses in Ukraine. I know that in Europe and in other countries there are these university programs. And I understand that it's not time to introduce this course in Ukrainian universities because it will take 4 or 5 years. But I believe that it's very needful if we start that kind of course in Ukraine. We don't know what will happen in 5 years. So when we're speaking about the training, depending on the branch, military doctor has to have their own professional trajectory. For instance, today we're speaking about license, certificates, all the things that are in the US. When you receive the certificate after finishing the internship, after that you might receive a document that testifies that you are a military doctor. And after that, in the brigade or medical battalion, people know who you are. Then people know what you can do in the military. Let's say you are busy with LTIS, or you are in tactical medicine field, or let's say you have many more skills. Everything is based on competencies of a specialist. We focus on those lists when we plan our training sessions. For instance, the courses of anesthesiology, spinal anesthesiology, and so on. There are also courses LTIS that we organize with our foreign colleagues, BLS, and so on. These courses are not obligatory for the military. This is a key aspect. These are individual initiatives that enable doctors of some military units to have this opportunity to do these courses. Unfortunately, it's not obligatory, and while it's not obligatory, it's very hard to speak about the quality of the whole system. We are speaking about the quality only in separate battalions based on the doctors that are there and their skills. Viktoriia, I had a question. How would you comment the idea of one of the famous political figures? She has written the draft law on medical assistance for the military, for the ones who are released from captivity. There is one thing that echoes with your presentation. Treatment and all the rehabilitation of the military, the veterans, the people held in captivity have to go, have to be aimed at restoring their full health. So what do you think about it? What do you think about this statement? In the ideal world, it would work. Unfortunately, we don't live in an ideal world. Mobilization, the drafting of people very hard. If we have a veteran, someone has to be there in the battlefield instead of him. So for us to be able to treat everyone, we have to substitute all the military that are in the treatment process. And it's not only because of the requirements of the state, it's based on the necessity, on the circumstances we live in. Fortunately, for the 4 years, we are proving to the whole world that we are independent. Although people said we would fall in 3 days, we keep doing it, and we can't do it only with the resources we have right now in the systems. Would we want to treat these patients fully? Yes, of course. But then we would need to treat everyone who is serving in the military. Maybe not physically, but the system of the mental health in Ukraine needs to be capable to provide this assistance for everyone who's serving. Thank you so much. I'll be short. First of all, I'd like to say thank you. To say thank you for everything you do. We know it, we see it. I have a question. A question about training. I know that the divisions you had it, they're always pioneers. But what do you think? How can you organize this training structure when the resources are limited? The doctors that are working have to teach. How can we do that in the conditions of the limited resources? How can we organize these processes into a system? I'll tell you 3 things how we can do it. First of all, we need to attract those who are able to teach, not to send doctors to different places, but let's say take a surgeon and make them go to a brigade, to the place where they are treating the military, and in those circumstances, that surgeon can show them how to work with the equipment they are working and what they can do. The second option is to provide training sessions while there is a period for a retreat period for the brigades. And the third thing, we need to understand people, what they do. If people don't understand what the value of the training, they will not be able to benefit from this training. So it's highly important to explain them why they do what they do, to show them the possibilities for substitutions, how they can substitute each other, and also to show them all the processes from the inside.
I am going to now welcome to the podium Tamara McColl, who is a clinician, educator, and assistant professor at the University of Manitoba, and director of education, scholarship, and faculty development in emergency medicine. And she's going to be talking to us about crisis resource management, enhancing trauma care through simulation and team-based training. And you can take this. I know the deaf one is on. I'm going to make sure this one is off.
Добрий день. I'm going to be speaking in English. Is this on? Can you guys hear me okay? And are the translation services on? And they're accurate? Yeah? Okay. So fantastic. I'm excited to be here today. By training, I'm an emergency and critical care doctor in Canada. We're here in Ukraine right now doing medical missions every 6 months with a group from Canada, mostly from Toronto and throughout the West. So excited to be invited to come and join you guys all today this afternoon and talk about crisis resource management. So one of the hats that I wear is, I do a lot of education and simulation training within Canada, specifically within my own hospital, but also throughout the country. Kind of using simulation education in order to teach these principles that will enhance teamwork and communication in order to ultimately improve patient outcomes and save lives. I want to preface this talk by saying that this is a very safe and judgment-free environment. I hope that you guys feel free to interrupt me at any point throughout the presentation, ask questions. I want to hear about your own personal experiences because not everything is going to be fully applicable to the setting in Ukraine. We'll certainly have a little bit of time towards the end for additional questions or discussion. So throughout the course of this presentation, we're going to talk about a few things here. Is there a clicker? Oh. Perfect. Thank you. That works? Okay, perfect. So at the end of this presentation, I hope that you're all going to be able to identify a few non-technical skills that are important to effective crisis resource management and explore their impact on patient care. I think an important topic that kind of also stems from the previous talk is analyze how workplace incivility disrupts teamwork, team dynamics, and clinical performance, and discuss some strategies of enhancing interprofessional and interdepartmental collaboration to enhance team performance and patient care. And specifically, we're going to be using simulation education as an example for that. So let's start with a quick reflection here. I want you guys to really think about what the toughest days in medicine have been like for you. So in your jobs, in your everyday clinical environment, what have been the toughest days? Is it that, big trauma or multi-casualty event that you had to deal with from a medical perspective? Was it perhaps an end of life discussion that you had to sort of get into? Or was it because of unprofessional behavior in your workplace? Or perhaps a very unprofessional or uncivil interaction you had with a colleague? So just kind of sit with that for a little bit and think about that as we move on to the next slides here. So I wanted to start this off by talking a little bit about incivility because I think it permeates medical culture, across borders. It doesn't matter whether you're in maybe a slightly more hierarchical environment in Ukraine or in Canada, where we're said to be a bit more progressive, but still the medical field lags behind and incivility certainly is still a prominent feature. So incivility in medicine represents sort of this pervasive issue that's rooted in our profession's unfortunately deeply hierarchical structure, where we do have fairly rigid power dynamics. And whether that's between, surgeons and physicians, senior doctors and junior doctors, whether that's between doctors and nurses or other allied health professionals, those sort of uncivil or unprofessional behaviors certainly do have significant impacts not only on individual performance, and we'll talk about that with a little bit of research, but also on patient outcomes, and has a significant impact on patient care. So how does it actually impact patient care? So when we talk about uncivil or unprofessional behavior, it can actually result in poor communication, lack of collaboration or teamwork, poor information sharing across the healthcare team. And all of that then leads to medical error, and it certainly stifles dissemination of safer medical practices, can end up delaying diagnoses for your patients, can result in unnecessary testing when we don't communicate appropriately, certainly results in medical error, unsafe practices, and loss of confidence, and not just loss of confidence sort of amongst our colleagues, but also loss of confidence in the patient and the healthcare system. So surprisingly, or perhaps unsurprisingly, there is actually quite a large body of research specifically on the impact of incivility or rudeness on medical team performance and patient outcomes. So this is a really, oh, it's not flipping the slides here. Apologize. So this was a very interesting randomized control trial that was published in Pediatrics by Riskin and colleagues back in 2015. So this specifically looked at incivility and its impact on team performance and ultimately patient care. And they observed that interdisciplinary resuscitation teams working on simulated neonatal emergency scenarios, they assessed their diagnostic and procedural performance afterwards. So they had an entire multidisciplinary team working on simulated children and sort of assessed their diagnostic and procedural performance. And groups were either exposed to a rude team member or neutral team member throughout the simulation, kind of an integrated actor throughout the simulations. And they found that teams who faced rude interactions performed worse than their patients that had the neutral actor in the room. So rudeness alone explained nearly 12% of the variance between team performance between the two different scenarios. So put simply, when someone in a team is uncivil or unprofessional or rude, that team is negatively affected, and so is their patient. So here's another example in a surgical setting. So this is a paper published in BMJ Quality and Safety in 2019. So Cates and colleagues performed a multi-center randomized control trial at 3 different academic centers, in which anesthetists were randomly assigned to a simulated operating room during an operative crisis. So a patient was hemorrhaging, and they inserted either just a normal neutral surgeon into the scenario or a very rude surgeon, and they wanted to see the outcome. And the anesthetists who were participating in these simulation scenarios were blinded to it. And performance was assessed. The authors found that those exposed to incivility scored significantly lower on every single performance metric that they analyzed, including ultimate patient outcomes. So only 64% of anesthetists meeting performance standards in the rude group versus 91.2 in the control group. So they found that rudeness impaired both technical skills, so their ability to perform procedures, get the airway, initiate massive transfusion, etc., as well as non-technical skills, so leadership, communication, teamwork. There is an excellent website that I would urge you all to check out at some point throughout your institutions. I put QR codes up on the slides if you'd like to look at any of these papers afterwards. But if we think about the perspectives in which most of our teams operate, we realize that it's often a hospital or departmental culture that excuses a lot of the incivility. So this group, Civility Saves Lives, provides a whole bunch of different resources that talk about the different elements that lead to uncivil behavior and provide a lot of evidence. So there are a lot of posters, infographics, and resources, as well as presentations that they have available that you could use at your own hospitals. So this is one of the examples from their website of an infographic that's available. So we actually printed a few of these off and put them up in our hospital and physician lounges and offices. And this one particular infographic looked at a study and underscored the dangers of incivility within the clinical environment. So this one, for example, showed that 61% of recipients of incivility had a decline in their own cognitive ability. So think about that. You were involved in a negative interaction with a colleague, and that resulted in a marked and statistically significant decline in your own ability to make critical decisions and provide high quality care to your patients. They also found that being a bystander, so you weren't even involved in the interaction, you just witnessed the interaction that was rude or unprofessional between colleagues, that resulted in a 20% decline in your ability to provide appropriate care to your patients. And then incivility was found to also lead to poor team performance and worse outcomes in all clinically significant measures when it comes to patient care and patient outcomes, including mortality. So how can we overcome this? What can we do to improve our culture, start working together as a team, and perhaps improve our communication and ability to work together so that we can improve patient care. So there are a lot of different things that we can do, and a lot of literature that is published on this specific topic. I've put up a QR code with a paper by Kenji and colleagues, specifically on tribalism in the workplace environment. So what I mean by tribalism is, a lot of our specialties are quite siloed, don't communicate significantly together, and that siloed behavior can lead to poor patient outcomes. So they outlined a lot of effective strategies to enhance collaboration and improve relationships between departments, and also included kind of interprofessional collaborative strategies. A lot of these are quite intuitive, but I think, unfortunately are overlooked and are worth mentioning. Getting to know each other personally. So even friendly conversations during work hours, social interactions outside of the hospital really does make a difference when you have somebody on the phone or somebody coming into your operating room or recess room to assist with a case. Emphasizing our shared affiliations, developing sort of a mutual identity as healthcare providers rather than a hierarchical structure. So kind of flattening the hierarchy. And considering projects across specialties, so collaborative educational tools or events like simulation education. So in our own hospitals, we've integrated simulation education in the workplace, so in situ simulation, and we run them throughout departments. So they're extremely collaborative, involving surgeons, physicians, residents, medical students, nurses, allied health professionals, respiratory therapists, et cetera, that all work together collaboratively in order to save a fictitious simulated patient. So a lot of elements go into culture change and creating a positive culture, but what specific skills make that collaborative work in high stakes situations? What actually leads to improved patient outcomes? So all of us in this room, I'm assuming, are medical professionals. We've taken significant training in order to be able to do our jobs. And we have a high level of technical skills. But I'm going to argue that the non-technical skills are equally as important in high-stakes situations in order to save lives. What I mean by non-technical skills are the things that often are overlooked and not taught properly in our medical training. So the communication piece, the collaborative piece, the ability to lead a team, the ability to communicate effectively and to sort of come together in order to provide appropriate patient care. And that incivility permeates into this, right? So how to treat each other with respect so that everybody in the room feels that it's a safe environment to contribute and ensure that the patient has a good outcome. Has anybody heard of the Elaine Bromley case? No? So this is a very, very famous medical case that's used in the patient safety quality improvement literature. Elaine Bromley was a 37-year-old mother of two. Her husband was a British Airways pilot. She was going in for a routine sinus surgery. Nothing impressive. She had no past medical history. Her preoperative anesthesia assessment was completely unremarkable. And the plan for the OR was for her to get a laryngeal mask airway and have this simple surgery and be discharged on the same day. So it was a day surgery clinic. She arrived, they induced her and attempted to insert the LMA. And unfortunately, they ran into a can't intubate, can't ventilate situation. The LMA wasn't fitting appropriately. Her oxygen saturations were dropping. Another anesthetist from an adjoining operating theater did come in and try to assist. There was very poor communication in the room, lack of leadership. Nobody took control of the situation. And there were attempts to do the exact same thing over and over and over again. Finally, the ENT surgeon came in, the one that was supposed to do the operation in the first place. He then persisted to do the exact same airway maneuvers in order to try to secure her airway. In the meantime, 35 minutes had passed, and her oxygen saturations had been around 40% for at least 12 of those minutes. Her induction agent finally wore off, and they were able to wake her up, meaning she was able to breathe a little bit on her own, but she suffered a massive anoxic brain injury and ultimately was taken off life support about 12 days later. and died from this routine operation that certainly could have been a preventable death. Interestingly, they did an inquiry into this particular case afterwards that was led by her husband, who trained in the aviation industry, where crisis resource management, a topic that we're about to talk about, was developed and is used in all of their aviation training. He requested an inquiry. He didn't want anybody sued. He wasn't looking for money from the hospital. He just wanted education to be brought into the medical field to enhance team training to prevent additional deaths like his wife. So from the inquiry, they found that the operating room nurses, there were 4 of them, one actually brought a surgical tray up to the front of the bed and put it down. She knew that the patient was critically hypoxic for a prolonged period of time, didn't feel comfortable from a psychological safety perspective to speak up, but did drop off the tray for them and was ignored. The other 3 nurses in their interviews, it was determined that they were also very aware of what was happening, that the patient was critically hypoxic, that the same maneuvers were tried over and over again, but again, they did not feel comfortable speaking up. One, in fact, actually called the ICU for help and was told to cancel that assistance, to not bring down the code team. So a lot of things went wrong in this case. From your perspectives, have you had similar situations where you saw a breakdown in communication, a lack of leadership, maybe a lack of collaboration within your own teams that led to poor patient outcomes? Nobody feels confident to speak up? That's okay. So lots of lessons learned from this particular case. And you'll notice in a lot of the patient safety quality improvement textbooks that this case is brought up a lot. And crisis resource management, actually, when it entered the medical field, anesthesia was the first department or the first specialty to adopt this method. And so you'll find the Elaine Bromley case prominent in a lot of their textbooks. But I think the lessons that we can take away from this case is that error is ubiquitous in medicine. It's common, it's pervasive. All of us are human, we make mistakes. How we learn from those mistakes and change our subsequent behavior and practice is what differentiates an average from an elite team, or an average or an elite clinician. And this case also highlights that the non-technical skills, right? The communication, collaboration, teamwork, effective leadership, all of these aspects in medicine are equally as important in patient outcomes as the technical ones. It doesn't matter if you are the most skilled clinician, if you can't work within a team when the time comes and during a critical event in order to save your patient. It doesn't matter that you have excellent surgical skills if a crisis breaks in the operating room and you can't work within a team and coordinate and communicate effectively in order to provide the appropriate treatment. So medical error is pervasive. It accounts to sort of mortality from medical error is amongst the top 10 leading causes in the developed world. And the Institute of Medicine published a landmark paper in 1999 highlighting that one of the leading causes of mortality in developed countries is from preventable medical error. So in Europe alone, and I looked up this statistic sort of coming here, there are over 165,000 deaths every single year that are attributed to medical error alone. So that's more than 1 plane full of people per day in terms of the amount of deaths that occur because of preventable medical error. And we talk about preventable medical error, 70% of that is attributed to human factors. So communication, collaboration, all of the non-technical skills. So when we talk about a solution for this, just like any other sort of problem that we may encounter, we have to think about it from multiple angles. We have to consider all the factors that contribute to it. So we have to consider the complexity of the task, right? So there's a clear difference in the risk of error if you're performing a very simple cyst removal versus leading a very unstable trauma resuscitation. You also have to consider the acuity of the situation. Is it something new or is it something chronic? The timing of the situation is a huge factor in medical error, right? So when our medical students transition to interns or residents, during that sort of 1 to 2 month period, in Canada, we call it the July effect because that's when they start, there's a massive increase in patient morbidity and mortality. Why? Because we have junior doctors that are unsupported working independently, especially at night. And that's the other thing that's very pervasive in the literature. Medical errors occur more at night. And why? Because we have unsupervised staff working and all of the other human factors that come into play during the night period, where we're perhaps fatigued, stressed, and unsupported. There are individual factors that certainly play a role, team factors in terms of role confusion, authority gradients that we discussed, and certainly environmental factors. So if you think about a resuscitation or an operation in which the patient is bleeding excessively and becoming unstable, there are a lot of different things that play into how you're going to perform or respond. There are a lot of interruptions that can occur. There's a lot of noise in the room, incomplete communication, equipment failures, lack of resources. There are a lot of considerations when thinking about how to prevent this. So that brings us to crisis resource management. So this is a systematic approach to managing human and technical resources during high stakes medical situations. So this refers to all of those non-technical skills required for effective teamwork. And this concept arose from the aviation industry, and it came during a time where about 70% of airline crashes were because of those human factors, because of lack of communication, lack of collaboration, and now it is integrated into the medical field. So there's a lot of research in this area, and we'll talk about a little bit because I'm sure that there's still some skepticism around sort of the importance of crisis resource management in medicine. But these non-technical skills in medicine encompass all of the cognitive, social, and personal resource skills that enable all of us healthcare professionals to work effectively in high-stress situations. So these skills complement all of the technical skills that we've learned throughout our medical training, and they're crucial for ensuring that we have effective teamwork, communication, and decision-making during emergencies. So effective CRM in medical environments centers on clear leadership with role clarity and task delegation. Communication must be closed loop, and we'll talk about what that is, with explicit messaging and structured handoffs. Situational awareness requires continuous environmental scanning and sort of sharing our mental model and anticipating what the next steps may be. Decision-making should follow systematic approaches with frequent reassessments and willingness to adjust our plans and getting input from the rest of your medical team. And team dynamics have to demand mutual respect, psychological safety so that people feel comfortable speaking up during resuscitations and critical events, and certainly flattened hierarchies during emergencies. So there's a lot of published literature around the efficacy and real mortality benefits of implementing structured CRM models within your departments and within your hospitals. I'm not going to get through all of that today. That would be like an entirely separate talk. But why does it work? I mean, it addresses all of those human factors that we talked about that contribute to 70 to 80% of medical errors. And CRM creates predictable communication patterns that can be implemented and learned. They can be taught easily, and they enhance team cohesion and create psychological safety. So real mortality benefits for your patients is the point that I'm trying to underscore here. So one of the main pillars of CRM is role clarity and effective leadership. So Kunzel and colleagues, they published a paper in 2010 in which they actually observed and studied cardiac surgery teams. And they wanted to find out what led to medical errors and poor patient outcomes amongst the cardiac surgery teams at their hospital. And in their analysis, they found that role ambiguity was the strongest predictor of team errors. So having a lack of a leader in the room and having lack of role clarity for all the other members of the team led to poor patient outcomes. Teams with clear role assignments had 40% fewer task errors. So just let that sit for a little bit. There's a lot that can be talked about leadership during crisis situations, and in a very time-based situation where things are critical, maybe you have to be a bit more directive when time allows, to be a little bit more collaborative. But a lot of the other elements that we're going to talk about, it doesn't matter if we're in a crisis situation or we have a little bit more time, they certainly are applicable regardless. When you're leading a crisis situation, maintaining global awareness of all aspects of resuscitation are key. And so that's why that role assignment is so important. You as the leader can't do it all. You can't lead a resuscitation while intubating somebody, while putting in chest tubes, while stabilizing their pelvis. As the leader, you have to take that step back, have that global awareness, that 10,000-foot view, and coordinate the chaos. You have to ensure that every member of the team has an appropriate role, that it's clear, it's directive, that they know what their responsibility is, and your job is maintaining that situational awareness, knowing what's going on, what the roles and responsibilities are, what the abilities of every single member of the team are, and ensuring that it's coordinated effectively and communicated effectively. What I mean by situational awareness is having that global awareness, right? So gathering relevant information. So maybe at the beginning, that foundational piece is looking at vital signs, gathering the history, having somebody run and gather the patient's past medical history or past surgical history. The challenge is in those first moments, there certainly can be informational overload. So there has to be some element of filtration. But that's the beginning piece. And then the second is interpreting that information. So you have to analyze it at the same time. So go beyond just seeing. You have to interpret what the information means. And we do often rely on pattern recognition or trends and relationships as we go through that period, and seeking input from team members. So a big part of situational awareness is ensuring that everybody in the group is on the same page. So frequent summaries as you're leading a resuscitation. And then predicting future states. And I often include this in my summaries. So, this is the situation. This is my interpretation of the situation. This is what I think the next steps may be, or how this patient may respond or may deteriorate. And this is how we're going to address that. And that leads us into a communication template. Does anybody use the SBAR template at your hospitals? So a few. So you're probably well aware of this framework, very well published in the literature, taught fairly universally. But it was developed by the US Navy for nuclear submarine communications, actually, initially, and now has integrated into the medical field. But it really matches how clinicians are trained to think. So what's the situation? What did the patient come in with? What's our assessment? What's our clinical judgment? What do I think is going on based on the information that I have? And based on that information, what is my recommendation? So what's my treatment plan? What are my next steps? So there's a lot of research on this particular framework for communication, and has found a 25% reduction in communication-related errors, and a 30% improvement in nurse-physician communication satisfaction. So like a pretty big impact on quality of life in your clinical environment, your relationships with your team members, and also improved outcomes for your patients, having a structured communication framework. I had brought up closed loop communication before. Is this something you guys frequently practice at your institutions? So what I mean by that is I may be in a resuscitation and I will ask somebody for 1 milligram of epinephrine. You have to be very specific when you ask for things. So not just what the drug is, the route that you're going to administer it through, and the dosing. So I may ask, can you administer 1 milligram of epinephrine intravenously? Let me know when that's done. She will then receive that information. She'll clarify that she got the dosage and the route right. 1 milligram of epinephrine, then go up and draw it. And prior to administering it, clarify the dose again, administer it, let everybody in the room know that it's been administered. That way, you know that the orders that you're providing, any kind of clear direction that you're giving to your team is actually being followed through on, that the patient's actually being administered the medication that you're requesting. Without this, a lot of those orders may fall into the ether and get lost, and unfortunately can lead to poor patient outcomes. And then critical language escalation, and this is challenging, right? So in our clinical environments, there always is some form of a hierarchy that, you know, whether is real or not, often just perceived, but there is a little bit of a hierarchy, and some members of the team may not feel comfortable speaking up. And so when there is a critical issue, like for example, you know, a trauma patient comes in and all of a sudden, you know, after stabilization, they start deteriorating again. And so maybe the physician thinks that this is related to their initial trauma, and so they're going to continue their massive transfusion protocol. But the nurse identifies actually they're developing urticaria. They're developing signs of anaphylaxis because of the antibiotics we just administered for their open fracture. If that information is not perceived appropriately because of that perceived hierarchy, or maybe the nurse didn't feel comfortable bringing it up, we have to have some sort of a framework in which every single member of the team can bring up or escalate critical information. And so there is this CUS framework, concerned, uncomfortable, stop. So if your initial sort of comment to the team leader during high crisis or high stakes situations is not sort of met and acknowledged, there is a framework that can be followed that in a very respectful and collaborative way can sort of escalate things a little bit further. So sort of step one is concern. So it's that initial level of escalation. So I'm concerned that we may be missing another cause for the patient's instability. Have you considered anaphylaxis? If that is not acknowledged, the next step would be uncomfortable. So I'm uncomfortable with this plan, given my patient is developing diffuse urticaria, which may indicate anaphylaxis. And then the lastly is stop. You know, there's a safety issue here. So I need us to stop and reassess this situation. So this CUS framework is what it's called, is quite diffused throughout the literature, specifically in patient safety quality improvement, and is taught in a lot of CRM courses. So how do we master these skills? So there's a lot of ways this could be taught. Unfortunately, didactic environments like this aren't the most useful. And that's where healthcare simulation comes into play. Who here has simulation education at your institutions? Just a few. So not a lot are engaging in simulation. So medical simulation, for those who aren't familiar with it, it really is an evidence-based educational methodology that replicates clinical scenarios in controlled environments, typically using mannequins, but certainly can use virtual reality or standardized patients or actors, depending on sort of what resources you have available to you. So it can be absolutely cost-effective, but it allows you to practice in environments where you don't have that risk to patient care, where participants feel a little bit more safe to practice and make errors, and where psychological safety and teamwork and collaboration can also be practiced in addition to the technical skills. So why simulation for trauma? So trauma remains a leading cause of death globally. I mean, that's unfortunately the reality, even more so here in Ukraine. I mean, you've seen firsthand how quickly well-coordinated teams can stabilize a patient, and conversely, how communication breakdowns can lead to critical delays and poor patient outcomes. And modern trauma care isn't just about individual clinical skills, it's about how quickly and effectively an entire team can work together. So studies show that even experienced clinicians can improve their performance by 20 to 30% through structured team training. That's massive and have very big impacts on our patients. So there are four main pillars of trauma simulation that I'm going to talk about. So the first is psychological safety. So this might be the most challenging aspect, especially when we have very ingrained hierarchical cultures within our medical systems. But here's what we know. I mean, the best trauma teams are those where a nurse can stop a procedure if they notice something's wrong, where a junior physician feels empowered to contribute and interrupt and question the direction of a senior physician. I mean, this does not mean chaos. It means structured empowerment with very clear defined roles, and really leads to a more collaborative and safe environment. Deliberate practice, the second pillar there, it's different than just practicing the same procedure over and over and over. What I mean by this is practicing at the edge of your current ability, getting immediate feedback and coaching, and progressively increasing the difficulty levels so that you can continually grow and practice. So for trauma teams, this might mean starting with a very straightforward motor vehicle collision. And then once the team is able to effectively resuscitate that patient with a simple scenario, then adding on additional layers to that. So maybe we'll add on a difficult airway. Maybe we'll create a mass casualty situation where the team has to manage 3 patients at once. Or maybe we'll add in some equipment failure, or perhaps an actor comes in and provides a situation where there is some sort of interpersonal conflict or uncivil behavior, to see how the team is able to coordinate that and deal with it together. So kind of pushing them a little bit beyond their comfort zone every time. Multidisciplinary integration. This is huge, especially for trauma teams. So this requires shared mental models. Everybody on the team has a similar understanding of the situation. It requires very effective communication so that everybody knows what their role is and what the plan is moving forward. And it's challenging in trauma care because team composition can change frequently. We often have ad hoc teams. Not everybody knows each other, and there often are a lot of bodies in the room. But simulation allows teams to practice these transitions and handoffs and practice communications even when people don't know each other. And then scenario realism would be that fourth pillar. So what I mean by that is the fidelity of the simulation. And that can sort of be looked at through 3 dimensions. So there's the physical fidelity, so how realistic the equipment is. So, I mean, mannequins, there has to be a certain amount of buy-in that comes into that from the team. And that's why there's the importance of a pre-brief before you actually start the simulation. I'll talk about that in a second. The other dimension would be psychological, right? So like, how real does that stress feel? And that often comes from, you know, how you designed the situation. And if anybody here wants additional resources or some templates for designing simulation cases, I'd be very happy to share. I have a lot of trauma-based ones or other areas of medicine as well. And then the third would be conceptual. So how well the scenario matches real clinical decision-making. And high-tech mannequins aren't always necessary. Sometimes the most powerful learning comes from standardized patients or even simple role-playing exercises. This does not have to be a very high-cost educational strategy. So lots of evidence in the healthcare setting that simulation both improves team performance, individual performance, procedural skills, as well as team-based training. And I don't think we have to get into each of these studies individually, but I'd be happy to share those resources if you'd like them. But a lot of factors to kind of consider when thinking about team performance in emergencies, specifically in a trauma context. So, you know, a big resuscitation comes in, the cognitive load is immense, multiple vital signs test results, interventions to track, lots of procedures that have to be performed simultaneously. And unfortunately, a lot of role confusion does occur. So this is where that CRM piece does float into simulation. Communication breakdowns are very common under stress and with a lot of bodies in the room. And the time-sensitive nature of trauma amplifies all of those challenges, but simulation specifically addresses these issues by developing that shared team mental model through repeated practice, creating psychological safety so that every member of the team feels confident and empowered to speak up and participate effectively in the resuscitation, and using structured debriefing to identify and address teamwork gaps. And the focus very much is on teamwork gaps and teamwork improvement rather than individual errors. So lots of different resources available for simulation team-based training. Team Steps has a lot of resources that are available online and programs that can be taken, but that's team strategies and tools to enhance performance and patient safety. It's a comprehensive framework developed by the US Department of Defense. And it's based on crew resource management, so again, from the aviation industry. So this program focuses on leadership, situational awareness, mutual support, and communication. And through implementation of these types of programs specific to team steps, it led to 50% reduction in medical errors. So again, more evidence that team-based simulation training is highly effective. In situ simulation, what I mean by this is actually practicing simulation or running simulation within the environment in which you work. And it really provides a little bit of enhanced realism, and sort of in addition to just learning the teamwork dynamics and perhaps the clinical elements that are coming into play with the scenarios that you're running, there's that added element of we're working within the environment that we're in every single day, so we can identify latent safety threats to our patients. We can work on quality improvement initiatives by running simulations in the environment in which we work. And we can identify vulnerabilities not only in our team, but within the environment. So again, showing lots of resources available and research on simulation for process improvement, so specifically quality improvement. So lots available, and not something we need to address today. But specific to the Ukrainian context, I think a lot of skepticism is around, would this work in our environment? Is this cost effective? Can we do this? A lot of simulation facilities that are available in the West are $1 million complexes. And I think I've mentioned this a little bit throughout the talk. You certainly do not need to spend $1 million in order to have an effective simulation program. There is a lot of low fidelity simulation that can be implementing or even using role playing or trained actors. So certainly is feasible. There are a lot of resources online. You don't have to develop it on your own. And it certainly is something that could be shared and collaborated with multiple facilities throughout the region. So I think one of the other pieces that I'll briefly talk about is, once you've run a simulation with your team, how do you talk about it afterwards? And I think the biggest thing to sort of impart here is when you're running a simulation, you have to sort of approach it with the perspective of this basic assumption. And we actually have a massive placard in our simulation lab and within our department that says exactly this. So we believe that everyone participating in simulation education is intelligent, capable, cares about doing their best, and wants to improve. And that again takes away from that sort of stress of participating in something that you think that you're being evaluated on. That's not the purpose here. The purpose of simulation is to enhance confidence, teamwork, communication, and yeah, you might learn something clinical that might be useful as well, but the primary focus is on the non-technical skills. And so by just participating in simulation, you've already identified that you care, you want to improve, you want to do your best, and you've completed your medical training, so you must be quite intelligent and highly capable. And so if you approach it and frame it this way, in and of itself, that creates already an environment of psychological safety. And then certainly starting the simulation with a pre-brief, setting the stage of psychological safety, letting everybody know that it's okay to make mistakes in this environment, that you're not going to be penalized, it will not affect your job, and most importantly, it's not something that's going to be talked about outside of the simulation. So Vegas rules apply, okay? So what happens in Vegas stays in Vegas. What happens in simulation stays in simulation. And, clarify your objectives during the pre-brief, talk about the environment, acclimate everybody to the simulation mannequins in order to get them to buy into the fidelity. So it's hard when you've never participated in simulation to look at a mannequin and treat that as a real patient, right? So getting that buy-in right off the front and kind of setting the scene, easing the tension and taking away the stress can help your participants be a bit more confident when they approach it, and letting them know that there's going to be a debrief following the simulation that's not going to focus on the leader's primary abilities or the way that they ran the case, but how the team ran the case and how we can improve team performance. So that certainly is the focus. Simulation debriefing, unfortunately, is a very complex and very different approach to discussing critical situations. it's outside of the scope of today's talk. If anybody wants additional resources, I'm happy to provide them. But very briefly, debriefing provides opportunities for exploring and making sense of what happened during an event, and discussing what went well and identifying what could be done to change, improve, or do differently next time. If you're going to read any papers on debriefing, if you're just going to read one, I would very strongly suggest to read Jenny Rudolph's paper. So she works out of Harvard. I did my fellowship with her, and she published this paper on debriefing with good judgment. And so the central rule in her paper is don't make assumptions about performances. Don't assume that they didn't know it for reason X, Y, Z. Your job as the facilitator, as the educator, is to take the time to uncover the reasons behind decisions, because you'd be surprised. And then the other sort of part is the non-judgmental part. So ensuring that you're maintaining psychological safety at every aspect of the debrief. Lots of tools available that might help guide you if you are planning to integrate simulation training and engage in some debriefing, either with your colleagues or with your learners. This is a very easy framework to follow. It's called the PEARLS framework. The Debrief to Learn site that I've put the QR code up there has a lot of free resources and posters and like printouts that are available. So you could probably get quite a bit off of that website. There are a lot of different methods of debriefing, but I think the PEARLS framework integrates a lot of the different methods and makes it quite simple and provides a really nice framework that then standardizes it, right? Because if one physician leads one simulation exercise and then your team is getting another one a month ago and they're following a completely different framework, that's again going to take away from the confidence and safety of your team, and they won't want to participate anymore. So how do you actually implement simulation within your program? So a lot of skepticism, I think, initially comes up if this is not something that your hospital or department is used to or has ever engaged in. And so everybody's going to start thinking about the barriers initially. And yeah, there's some barriers, but there are a lot of good solutions too. So when we think about a hierarchical culture that maybe exists, traditional power structures, you have to think about, well, but if we get leadership to buy in, and if we develop sort of local champions within our group that have bought into it and can model and get involved and do some peer-to-peer education, that in and of itself is huge and can make a big difference. We think about time constraints. We have a lot of patients, we're very busy. When are we actually going to engage in the simulation exercise? We can integrate micro-learning. These don't have to be hour sessions. Within our department, we do 20-minute simulations. They're very quick, 15 minutes for the case, 5 minutes for the debrief. So micro-learning is a very easy way to integrate simulation into your clinical context. And then resource limitation. When you think about, well, we don't have simulation equipment and we don't have the money to be able to implement something like this. Well, we've talked about that. You can use low fidelity simulation. You don't have to buy the very, high-tech, high-fidelity simulation mannequins. And then a few tips for success. So, performing a needs assessment often makes people feel like they've been part of the process and have had a voice when implementing a new program. So when you think about change leadership or change management, one of the things that always is used sort of right off the bat is conducting a needs assessment within your group. So getting their buy-in and provides a little bit more communication and gives them a bit of a heads up before you start. And then the leadership buy-in and stakeholder engagement is huge, right? So getting, the key members of your faculty involved in it from the beginning. Then doing some faculty development to ensure that you have enough facilitators that are able to provide that structured debriefing and run effective simulations in a very psychologically safe environment. And then case development. There are a lot of cases that are available online and wouldn't cost anything. So again, cost effective. And then lastly, logistics. So, seeing what time within your department would be the best to run it. Often our nurses are excellent resources for that. And developing a regular schedule so that, it doesn't run out of steam. You want to ensure that it's done on a regular basis so that people, become accustomed to it and it becomes part of their regular clinical work. So that's it for today. You know, I want to emphasize that simulation isn't just another education tool. It's a transformative strategy that can really elevate medical care, improve patient outcomes, enhance collaboration and teamwork, and kind of break down a lot of those silos between our departments and between disciplines as well. So I hope that was useful. If you guys have any questions, I'm happy to answer them.
Thank you very much. Any questions? Maybe I'll start at the back.
Fantastic talk, thank you so much. I'd just like to know your views on virtual reality simulation, because we're seeing a huge increase in the number of sort of VR companies coming in, offering virtual reality surgical simulations all the way through in the neuro field. Where are we at the moment with the development of those?
That's an excellent question. That's going to be the future. We saw it being integrated a lot during COVID, wherein a lot of programs couldn't actually hold structured simulations within their departments, specifically in medical schools and residency programs, because the universities were protecting them. In the in situ environment, we were still able to continue doing simulations during COVID, but that's when the virtual reality sims really took off. And there were a lot of computer-based programs that were developed in AI-type programs as well. So Ottawa just actually published a paper a few years ago specifically on that, used in the emergency setting. There's not enough literature right now to know what the efficacy is, but you know, it's really gaining a lot of traction, and I suspect we're going to see a lot more of that in the coming years, especially with kind of resource-limited settings. As well as kind of rural settings where they don't have a lot of educators or debriefers that would be able to hold the sims. So even at our own shop in Winnipeg in Canada, we have a lot of rural communities that don't have effective educators or senior staff members that would be able to conduct simulations. We hold them over like Zoom FaceTime in order to be able to facilitate and debrief. So we hold the debriefs like online with people remotely. Yeah.
Okay, thank you. Oh, yeah, wait. We have one more question.
Yeah, I want to ask you about medical education programs. What do you think? What is the most good place for medical simulation in medical education? When the best started? On first courses to low fidelity, or on third or fourth courses? Thanks.
Yeah, that's a great question. I mean, it depends what resources you have available for you. It's difficult without having any knowledge to be able to start running simulations. But we actually, within our university, start simulations from their first year of medical school. And it's focused on exactly what we talked about here, is the non-technical skills. So even when they haven't acquired the medical knowledge yet, they can start working on effective communication. And we give them scenarios within their scope. So things that they would be able to figure out. And sometimes even not even a clinical scenario, but ways to deal with interpersonal conflict or sort of, we've integrated gamesmanship into their simulation as well. So high stakes games is gaining traction in the medical literature. But simulation integration is integrated rather within every level of education. If you are limited in terms of your resource settings, third and fourth year medical school, once they've acquired a little bit of knowledge, may be more effective.
Thank you so much.
Okay.
Thank you, Dr. McColl. Okay, so the next speaker is me, and I know that we're getting less and less people. Time is moving on. And we have more people leaving, but that's okay. At least for those who are interested in hear about transfusion, stay here and I can hopefully tell you about how we do it in Ontario. So these are my learning objectives. And I do want to say that, so my training is that I'm an internal medicine specialist, hematologist, and a transfusion medicine physician. And I work in a very large academic trauma center in Canada. We do not deal with children. So everything that I'm going to be talking about applies to adults. Children have very specific considerations. So this is where I'm from. This is my hospital. We actually have a helipad on top where our emergency transport service can land right on top of our hospital. The challenge in the place that I work is that it has a very large territory, but not so many people compared to Ukraine. And most of our people reside in the cities, which creates all kinds of logistical problems about delivering patients to where they need to be looked after. And I work in a level 1 trauma center that is accredited by the American College of Surgeons. And the other very, very significant thing is that we're very lucky, but in Canada we have a single blood supply, a national blood supplier, which means that if there is a shortage in one area, that shortage can be covered by products being transferred from another area. So what is massive hemorrhage? There is no universal definition. Usually, if you say that it's massive hemorrhage if more than 10 red cells are transfused within 24 hours. However, this doesn't really reflect the situation where you have very significant critical bleeding happening over a short period of time. We mainly deal with trauma, but it can occur, of course, in many other circumstances. It is a very rare, complex, and high-stress medical scenario. And in trauma patients, mortality rate is upwards of 50%. So it's a very high-stakes situation. And basically what the protocol is that you're trying to bring as many R's as possible, right people, working on right patients at the right time, doing the right things. So it's a protocol, and it just speaks to the standardization. And there's a lot of evidence in medicine that standardizing protocols can actually lead to better outcomes. There has been a lot of literature on what massive hemorrhage protocols can achieve, and some of them are easy to guess. Like, for example, if you have a protocol, you can imagine that the blood is going to come to your patient faster. We could have predicted that. What we also been able to show is that having protocols actually leads to a reduction in mortality, organ failure, and post-injury complications. And this is, I like showing systematic reviews because it sort of puts together the literature and shows you the conclusions sort of in a pictorial form. And you can see that in this fairly recent systematic reviews, having the massive hemorrhage protocol was associated with improved mortality. What's also interesting is that most people don't realize they get fixated on what is exactly in the protocol, even though that is really important. What is more important is to have the protocol in the first place and train people on it. And then you can make sure that your content is perfected. So I don't know how many of you are physicians and work in hospitals. How many of you do actually have a massive hemorrhage protocol? Okay, that's pretty good. I know that there is a national Ukrainian massive hemorrhage protocol. Let me ask you a more leading question. How many times do you actually follow it? So in the United States and in Canada, what we found is that even though everyone seems to have a massive transfusion protocol, what actually happens in real life is not what is written. And so there have been multiple papers, and this one is particularly funny because 6 years apart, they actually entitled "The Confusion Continues." And when we looked at our own state of affairs in 2017 in the province of Ontario, we have 150 hospitals with blood services, and we found that a third didn't actually have massive hemorrhage protocol. But even those, the majority that actually had them, had a number of problems. And you can't read everything on the slide, but you will be shocked to find out that approximately 50% did not include any targets for hemostatic resuscitation. How can you have a massive hemorrhage protocol if you don't even state where you need to be? 70% did not track any quality metrics. So again, how do you know that you're performing well? So our group got together, transfusion physicians, trauma surgeons, anesthesiologists, and created a multidisciplinary program. And we came up with consensus. What you see here are the guidance documents. And this publication is freely available. But as I'm going to try to convince you, just having a publication does not help. What you actually need is some sort of a tool on how to implement. And so we spent many years, and again, this toolkit is freely available for everyone who is interested in it, explaining how every single of these provisors can be implemented, coming up with smart records, coming up with presentations directed at various individuals, as well as coming up with videos of simulations on how to manage a massive transfusion in different areas. And the easiest thing to think of massive hemorrhage protocol is that there are the 7 Ts. It works really well in English language, doesn't work so well in Ukrainian. I tried to translate it and I couldn't come up with proper words. So the first T is for treatment of bleeding and triggering the protocol. The second one is for team, komanda. The third one is from tranexamic acid. Fourth is temperature, 5 is testing, 6 transfusion, and then termination and tracking performance. So what I'm hoping to do is, our numbers are dwindling, to quickly go over these 7 Ts and explain what the significance of them are. So the first thing is to stop the bleed. And this does not have to happen in the hospital. This can be done by a bystander who is trained. There is a Stop the Bleed video in Ukrainian you can watch on YouTube that talks about how you can stop hemorrhage even as the civilian. Now, of course, if you're in the hospital, that's when we start talking about damage control resuscitation. Again, you're controlling the hemorrhage, and you're hoping to provide definitive treatment, so surgery on embolization. And of course, if you cannot do that, you need to transfer the patient somewhere where this can be done. And then if you have blood, you're going to transfuse blood. And also you're going to manage low calcium, manage acidosis. They sort of fall under this general umbrella of damage control resuscitation and not specifically mentioned in the protocol otherwise. It is really important to know what the triggers of massive hemorrhage protocol are. There have been a number of scores published. Most of them suffer from the fact that they take into account laboratory investigations, which of course are not available to make that decision. So of course the vast majority of people would use either the ABC score if you're dealing with trauma, or you're dealing with a shock index. And shock index is my favorite. It's very easy to operationalize. Heart rate over systolic blood pressure. You can do it in seconds to make a decision whether you're going to call it or not. So I'm going to test your knowledge for those of you who are awake. So you have a 68-year-old man who has known alcohol-related liver cirrhosis. He just vomited blood, and his blood pressure is 157/95, heart rate 100. Does he need a massive hemorrhage protocol? So if you use the shock index, the answer is no. Even though it looks pretty bad, he does not need a massive hemorrhage protocol. In stark contrast, you have an 18-year-old male who is coming in with 2 gunshot wounds to his right lower chest and upper abdomen, blood pressure 95/60, heart rate 130. If you use ABC score or shock index, this is a person who clearly needs activation of massive hemorrhage protocol. This has been covered extensively by Tamara, so I'm not going to repeat it. But the problem is with massive hemorrhage protocol is that your team members will probably be people you've never worked with. They all come from different areas. There's hierarchies, there's silos, we don't talk to each other. And so the way you overcome this is by training, including simulation, and also having very good communication and debriefing. And so this is the picture of our trauma room in St. Michael's Hospital. As you can see, as the team members walk in for code, they pick up a sticker and they stick it on themselves, because when you're wearing shields and different attire and masks, it's very difficult to see who is who and who is in charge and who is carrying out what role. So very significant for role assignment, but also it's clearly visible what your role is. What you see on top, this is where the charting nurse sits. And there's a pre-made chart, there is a checklist, and in the little red bags, and they already have all the tubes available for collection of blood. Tranexamic acid is phenomenally important. I'm going to talk mainly about its use in trauma, but it has been shown to improve outcomes in postpartum hemorrhage as well as upper GI bleeding. The way you do it in trauma is that you need to administer it within the first 3 hours. And the original trials were 1 gram as a bolus and then 1 gram over 8 hours. Now most institutions have gone with tranexamic acid 2 grams within 1 hour. What happens if you give it after 3 hours? Studies have shown that your bleeding risk actually increases. And at first it seemed paradoxical, but it's actually quite clear that changes in coagulation system resulted in so being. And so if I give you this case of a 20-year-old female who is being crushed under rubble and arrives in the trauma center about 4 hours after her injury, and I will ask you, do you think this patient needs to receive tranexamic acid? Based on the best knowledge that we have right now, I would say that you should not be giving tranexamic acid to this patient at this point. when you should have been given tranexamic acid within the first 3 hours of injury. So therefore, in Ontario, our paramedics, our first response providers, carry tranexamic acid. Temperature is really important. If you're hypothermic, you will have high in-hospital mortality. If you're quite sophisticated, you can have blood warmers, and that's how most blood should be administered, with a blood warmer, but it's also really important to just keep the patient warm by whatever means necessary. Testing is really important. Testing will show you how well you're doing with your resuscitation, and testing will also allow you to provide compatible blood eventually. We mainly use hemoglobin, platelets, INR, PTT, and fibrinogen because they are widely available and you can get the results in under 15 minutes in my hospital. We do have viscoelastic testing. No one knows how to use it. No one knows how to interpret it. So despite all the evidence for it, we're not using it. How quickly and how frequently you're going to be doing this, we recommend that you do it at least hourly, but definitely for the duration of resuscitation, it is important to check. If you cannot check, then of course you're going to be relying on formulas and treat empirically. Quick reminder, some of our patients that you're going to be looking after, especially the older civilian ones, will be on anticoagulants, and you have to remember to ask whether there are anticoagulants on board, and you have to remember about the antidotes. The most commonly used antidote is prothrombin complex concentrate. It will deal with warfarin, but it will also allow you to deal with some of the 10A inhibitors as well. The other significant one is hemophilia. So hemophilia is actually quite common in Ukraine. And you can pour as much product as you want, but if someone has hemophilia without addressing the underlying clotting dysfunction, you're not going to be able to effectively control the hemorrhage. So it is extremely important that hemophilia patients actually carry some sort of identification card. This is definitely true in Ontario, and our paramedics are trained to look for that card and administer factor. And the program is called Factor First, so give replacement first before looking at other interventions. I'm going to quickly talk about transfusion. I am a transfusionist, so of course I'm highly invested in this. Talking about quality, it is important that your patient is identified. That may be very difficult. If you don't know the name, at least make up a name so you can know which patient you're resuscitating, especially when you're dealing with multiple patients. Mistakes do occur, and mistakes can be catastrophic and lead to death if you mistransfuse or give ABO-incompatible transfusion. It is also really important, because blood is scarce, to maintain it at an appropriate temperature until you're ready to transfuse. What you're going to give depends on what you actually have. So I know you have whole blood, silna kriv. It could be fresh from a walking donor, it could be cold stored, or you can have red blood cells. In terms of plasma, there are a few choices there. I know in Ukraine you have frozen plasma as well as freeze-dried plasma, and some of you are getting spray-dried plasma coming soon. Most commonly used platelets are room temperature stored platelets, but cold platelets are becoming more and more used, so cold or cryopreserved platelets may also be used. And then in terms of clotting factors, you will need, in order to replace fibrinogen, you will need either cryoprecipitate or fibrinogen concentrate, and you can use prothrombin complex concentrate in lieu of plasma, and I'll show you some of our experience with that. What about blood group? So, of course, you're going to be giving whole blood and RBC group O, or Persha Grupa. And you need to save this precious universal donor for everyone else who's going to come afterwards. So the impetus should be to determine the blood group and switch to the group specific as soon as possible. And of course, for plasma, you're going to be using group AB plasma or Четверта Grupa. It does not matter if you're using platelets or cryoprecipitate of any specific blood group. So this is what our protocol looks like. We suggest that you start with 2-to-1 ratio of red cell to plasma. If you don't have red blood cells in plasma, you're going to be using whole blood. And then you're going to switch to lab-guided resuscitation as soon as possible. And here are some of the hemostatic goals that we established by consensus. And it actually reflects what's pretty much in other literature as well. One of the most important things about massive hemorrhage protocol is that you're not thinking about what to order next. that the boxes just arrive, and they arrive at irregular intervals, and they contain predictable contents. So if you're in a big hospital like mine, what happens is that box 1 contains 4 red cells or 2 whole blood, and then the contents of the boxes goes as follows. Platelets arrive based on the platelet count, or after you've transfused 8 units of red cells. Fibrinogen concentrate gets issued as per fibrinogen level or with duration of resuscitation. If you have limited resources, and say you only have a couple of whole blood or a couple of red blood cells, what you can use is 4-factor prothrombin complex concentrate and fibrinogen concentrate. These products are available in Ukraine. They can be stored at room temperature. They come as lyophilized powder that can be reconstituted in sterile water over a period of less than a minute and pushed over a couple of minutes. If you're worried that maybe that will cause too much clotting, there are some studies that indicate that it is a safe approach, and I'm going to show you some of these studies. But first, I want to highlight that fibrinogen is your best friend in massive hemorrhage. It's the first one to fall. It's the most important one to form a clot, and therefore replacing fibrinogen is fundamentally important and should not be forgotten. Here are some of the studies, and again, you can read them. There's tons of them available, so what you have is some systematic reviews, and there are some studies. I'm just going to show you the 2 studies. The first one is quite old, from 2017, showing that compared frozen plasma to fibrinogen concentrate and showed that if you supplement with fibrinogen concentrate, patients do better. The other is a UK study from 2023, where they studied adding cryoprecipitate, which replaces fibrinogen concentrate up front, and they showed no difference. So a little bit of mixed bag, not really clear what to do. So generally now we suggest that you either give fibrinogen later in resuscitation or in response to some sort of a measurement, be it a fibrinogen level or viscoelastic testing. What about prothrombin complex concentrate? So there are 2 studies. One is from France, ProCoag, where 4-factor PCC was used in lieu of plasma, and it resulted in no difference in primary outcome. In other words, it didn't matter if you used plasma or 4-factor PCC, it worked the same. The concern with the French study was that there was a little bit more thrombosis in that patient population. So first 2 is our study that we ran in my hospital and many other trauma centers in Canada, where we used 4-factor PCC and fibrinogen concentrate, again, instead of plasma, and we compared it head-to-head with plasma. And it was just as effective and did not result in any thrombotic events. So I'm not saying that giving clotting factors is better than giving plasma. What I'm saying is that if you do not have plasma, use clotting factors. They're easily transported. You can put it in your backpack. They can survive extreme of temperature, can be reconstituted in the field and administered very quickly. Finally, you have to not forget to conclude the massive hemorrhage protocol, and that means returning all of these precious units that you haven't used back to the blood bank where they can be used for somebody else. It is important to complete documentation, and as Tamara discussed, it's really important to debrief. And you can do it hot versus cold. Hot means you do it immediately after, and you don't need to have long discussions. All you need to know, what went well, what could be done better. Or you can wait and do as a cold debrief, so a couple of days later, and ask the same questions and see if you can also get some reflection going after the event. No one knows which one is better. What's worse is not debriefing at all and not learning. It is also important to track performance. So ultimately, isn't that what we are here for, to talk about quality? We know, so Bevazir study is our study from St. Michael's Hospital, and these 2 studies are from the United States. And what they showed is that the level of compliance with massive hemorrhage protocol is very low. We do some things very well and some things very poorly. But if you do things well, you can save lives. So it is really, really important to do what is written. And so how do you know that you're doing well? So our Ontario massive hemorrhage protocol includes mandatory requirement for tracking performance. And you can see them listed here. And if you did it, you get a point. If you didn't get it, you get a 0. And all of these data entered into provincially reported outcomes that can be seen by patients and other physicians and CEOs of hospitals, so you can see how well your trauma center is performing as opposed to your peers. One of our initial readouts showed that, for example, we do some things really, really well. So, for example, we are very good at giving blood and maintaining hemoglobin above 60 grams per liter. And there are some things that we do very poorly. For example, we do not give tranexamic acid within 1 hour of activation in 52% of cases. So that's not good. What it allows us to do is to see what we need to do better and where we should direct our educational efforts. And again, why does this matter? Because doing these things correctly saves lives. So giving tranexamic acid within 1 hour of MHP activation is statistically significant associated with decreased mortality. So there are a lot of things that are really important. Keeping the patient warm, temperature more than 35 Celsius, is statistically associated with improved mortality. So when you are going to write or adapt a massive hemorrhage protocol for your hospital, remember the 7 T's. Remember tracking performance. And remember that doing these things right will save lives. Bleeding to death is the #1 leading cause of mortality in injured patients. So we cannot do anything about traumatic brain injury, but we can certainly do something about bleeding. And doing it correctly and teaching people about it is really, really important. So with that, I'm going to conclude. Thank you so much for your attention. I know we have one more speaker, and I know everyone is getting tired. So if you have any questions, you can ask me. Otherwise, I'm going to call upon our last speaker to present. I know it's a really long day. I know, it's really hard. If not, maybe what we'll do is we'll let our next speaker go. Let me introduce you properly. And if you have to grab a mic, what we're going to do is maybe afterwards, if anyone is interested, you can catch us and talk. Okay, so I'm going to introduce Michael Samotowka, who is a trauma surgeon and surgical critical care intensivist, and board member and humanitarian trauma surgeon at Med Global, trauma medical director and chief of surgical ICU, and you are coming from the United States. Welcome.
Thank you very much.
Definitely on.
This one's working. This one's definitely working. Okay. I don't know if it's a privilege or what to be the last speaker. I have good news for all of you. I was allotted 45 minutes. I will not take 45 minutes to give my talk, so we will end early today. Yes, thank you. First of all, where's this slide? So I'm going to talk a little bit about the Trauma Quality Improvement Program, what we call TQIP in the United States. Я україномовний, але я буду говорити по-англійськи, бо мені буде легше говорити так. And I'm going to is what the important role is in helping to improve survival and outcomes in trauma patients. And I don't see a slide. Okay, so it's my privilege to work with actually 2 NGOs, Med Global, which was one of the first NGOs, boots on the ground here in Ukraine. We're still here. We'll be going to Vinnytsia next week to do trauma training for the young trauma surgeons in Ukraine. And then I'll be back in November with the David Knott Foundation in Kiev doing trauma training. We come about every 6 to 8 weeks to train the young trauma surgeons who are working here in Ukraine. And this is here, still not moving. Okay, let's see. You'd think I would be able to figure this out. Okay, there we go. So why trauma quality improvement? So in Ukraine, we are now facing unprecedented trauma burden from war. In trauma surgery, we basically divide all trauma into three branches: penetrating trauma, blunt trauma, and burns. What we're seeing today is that 80 to 90% of the victims, of the patients, are actually victims of drone injuries. And the problem with that patient population is that they are a combination of blunt, penetrating, and burn. And unfortunately, because the Russian forces are using chlorine gas and other inhalation injuries, such as sufentanil, which stops your breathing or causes anoxia, we're seeing polytrauma patients. And those are very difficult and challenging patients to take care of. The first time I came to Ukraine was in 1992, and I've been coming here since then. When I would tell people I'm a traumatologist, they would ask me, what bones do you work on? They would think of me as an orthopedic surgeon, and I'm not an orthopedic surgeon. Just to give you a perspective, in the United States and Canada, to become a trauma surgeon is 4 years of college, 4 years of medical school, 5 years of general surgery, and 2 years of fellowship in trauma critical care surgery. And then every 2 years, I have to take a written exam in general surgery and trauma surgery and pass to stay certified. We don't have that field of expertise here in Ukraine. Now, I am told that the Ministry of Health is now actively looking at developing in medical schools and academies the field of trauma surgery as an independent field and a separate track. I would like to add to some of the excellent talks that came before me. And I believe in the first speaker spoke about the concept, well, in 5 years, this war is going to be over, so why should we waste our time training trauma surgeons? That's the wrong attitude to have. In America, we had World War I, World War II, we had Korea, Vietnam, Iraq I, Iraq II, Afghanistan. Every country needs trauma surgeons. I will never be unemployed. There will always be a need for trauma surgeons somewhere. And given the situation and the circumstances where Ukraine is located, the pull toward the West, closeness to Belarus, to Russia, this is an area of the world that needs trauma surgery developed as a field, critically important. Now, why do we want to improve the quality of the care? Well, so preventable deaths and disability still remain very high in our patient population here. We want to bring down the morbidity, want to bring down the mortality. How are we going to do that? Well, we start quality improvement programs. It's important not just to look at the mortality of the patients, but also the process that we use to care for those patients. So a perfect example from our last speaker is the massive transfusion protocol, right? Before, we would just give blood. Some of us would give blood, some of us would give crystalloid, some of us would give a lot of blood, some would give a little bit. We really didn't know what was the optimal care for patients. So by looking at how we treat patients, by vigorously reviewing cases, not just the deaths, not just the cases where things went wrong, but where things went well also, we are able to improve and shift the paradigm toward better care for everybody. Survival rates are a very easy objective parameter to follow, but they're actually a very bad parameter to follow. You need to look at other factors: length of stay in the ICU, risk of aspiration pneumonia, recovery, infection, okay, open fractures. We know now that antibiotics need to be administered within 1 hour of an open fracture because that statistically significantly improves and decreases the risk of infection. And this is all part of the TQIP process. No system, whether it's America, Canada, Ukraine, can have unlimited resources. We all have limited resources. Some of us, unfortunately, are more limited than others. So one of the advantages of the TQIP program is that it makes trauma care more efficient. We develop standard of care protocols. Everybody follows those protocols, and we're not wasting precious resources. And where this really comes down to is when the public sees that the hospital, the clinicians, the doctors, the nurses, the therapists are all pulling in the same direction to do the best for the patient, that builds a culture of trust by the community for the healthcare system and for the trauma system. All right, so let's talk first about some of the strengths that Ukraine has. When the escalation in the war started, there was a huge influx of NGOs, of international collaboration. We were sending physicians to Great Britain, to Denmark, to Sweden, to America, to Canada. We were getting training. We were sending people here. One of the frustrations that I have in this is there are so many NGOs working in separate silos and truly not collaborating together to maximize the good for the care of the patients. Everybody's kind of working in their own little direction. And so just this is some of the examples here, the TCC, ATLS, ACTT, with Med Global and the David Knott Foundation. We teach basically what we teach is called the ASSET course, which is head-to-toe anatomy and the basic maneuvers that a trauma surgeon needs to know when they're operating on a trauma patient. When this war started, everybody who was a surgeon became a trauma surgeon. So if you're an ENT, you're an OBGYN, you're a general surgeon, you're a thoracic surgeon, you're put on the front and you are basically taking care of things which you were very unfamiliar with. Today, 3+ years into this war, the best trauma surgeons in the world are here in Ukraine. We have more experience, our surgeons here, than anywhere else in the world. That's something to be proud of, but it's also a very sad fact of life. Now, other strengths. So, I am told, again, that the Ministry of Health has now begun to develop a registry for all trauma patients in Ukraine. I don't know exactly where that stands, because when I talk to people, I get a very different answer depending on who I speak to. This is something that's critical. Bad data in means bad data and no real data to work with to improve quality. So it is paramount for the Ministry of Defense and the Ministry of Health to collaborate and work together to share their knowledge, to share their experience, so that we get real data, because that's how we can make changes. Rehabilitation programs, I think we're in Lviv now, so everybody knows Unbroken, Superhuman, other rehabilitation programs around the country. 10 years ago, what was the state of rehab in Ukraine? Not very good, unfortunately. Now, imagine that you are now one of thousands of veterans who sacrificed for your country, and you're in a wheelchair, and you're riding along the cobbled streets of Lviv, and you need to go to a store or to a restaurant. So one of the evolutions of the TQIP program is identifying things that need to be changed going forward. We have an enormous need in this country to address the deficit in physical therapy, occupational therapy, speech therapy. Where I practice, everybody with a broken neck gets a speech therapy evaluation because they're all super high risk for aspiration, pneumonia, mucus plugging, and death. That should be the standard here as well. How many of our hospitals here have a designated, dedicated, trained speech therapist doing an evaluation on every patient with a neck injury or a head injury? Zero. Yeah. Well, it's not zero, but it's close to zero. You're correct. So these are the kinds of things that you learn when you put your efforts in to developing the best quality care you can for the traumatized patients. In all the courses that we've run here in Ukraine now, I do get a sense of a very strong clinician motivation to do better. People understand that there are needs, that we need to improve what we're doing here to improve the care of our patients. So, TQIP, trauma quality improvement, is not meant to be a malignant or a punishing factor. It's a culture of we all want to do what's better for the patients, and it doesn't stymie innovation. So a couple days ago, I was in Kiev at another conference, and we were talking about drone warfare, and one of the developments in Ukraine is the RORIG body armor. So typically, American and NATO forces have a body plate in the front, a body plate in the back. And what we've learned from drone warfare in Ukraine is that drones rain down under high pressure fragments, or if the drone drops its munition in front of the patient, the material, the fragments blow up. And so you see a significantly huge increase in head and neck trauma, axillary trauma into the armpits, into the groin area. And so one of the things that's been developed here in Ukraine is new body armor that is lightweight. It's kind of like the Japanese samurai, but it covers those areas where we're seeing more wounds develop from drone warfare, because 80 to 90% of all people injured today in warfare in Ukraine are drone related. That's very different than what we saw in any previous war. All right. So just like we have strengths, we also have weaknesses. Right now, we still don't have a fully robust national trauma registry. And that's desperately needed, because you really can't do anything until you have really strong, good data. For the most part, case reviews are limited to mortality or to what we call sentinel critical events. In the trauma center where I work, every case, good or bad, is reviewed by the trauma nurse. Those that there doesn't seem to be any problem or issue get put in the green pile. The next pile goes to the trauma medical director to be reviewed. If there's still a problem, it goes to what we call peer review, and it's presented. And when it's presented at peer review, we have representatives, all the trauma surgeons, the trauma nurses, we have the orthopedic surgeons, the neurosurgeons, the blood bank, the rehab. It's a multidisciplinary meeting. And it's not meant to be malicious or malignant or say, you did this wrong, you did this wrong. It's done in a constructive manner to enforce that we truly want to do the very best for our patients. Unfortunately here, we also have a very large variation in infection prevention, and that's related to the fact that many of these soldiers are in the field. I've heard up to 30 or more days laying in the field before they're able to be safely removed. And obviously that prolonged downtime significantly increases infection. Because of drones being everywhere in the field, it's difficult to get them out. And so we have issues with pre-hospital emergency system. We also have problems of communication, because patients arrive at a stabilization point, then they go to another hospital, then to another hospital, then to another hospital. And there's not strong communication between each of those hospitals. So if I'm a medic or a surgeon in the field taking care of a patient, I have no idea what's happening to that patient a month later. Is what I did correct and good? Or was there something I did that I should have changed, I should learn to do better? And that's a real problem. There has to be an improvement in the communication. We can't get patients off the field faster, okay, for right now because of this issue of drones. But what we can do is improve the communication between the different levels of hospital. We need a much better formal loop closure. So the doctors and medics that are working on the front line know that what they did or didn't do is proper and effective. And if it's wrong, or if it wasn't ideal, what can I do to be better? Okay, so what is TQIP, the Trauma Quality Improvement Program? So one of the nice things about TQIP is it was created by the American College of Surgeons. And that immediately adds strength and backup. The administration, the highest level of care for surgical patients, said, we are going to do this nationally. There's buy-in at the highest level. Parallel to that, here in Ukraine, what we need is buy-in by the Ministry of Health and the Ministry of Defense that they need to follow in their own way the TQIP pattern. It's standardized trauma registry data. There's over 100 points of information that are collected on every single trauma patient. And the results from one hospital versus another are public knowledge. You can go on the internet and find out exactly what your chance of survival is in my trauma center versus every other trauma center in America, and I think for Canada also. 2, okay. But the reality is we can't hide. Every time we mess up, you can find it on the internet, and it's very easy to look up. So if you come to my hospital and you have a ruptured spleen and broken ribs, the family of that patient can look on the internet and tell me that there's a 3% chance that patient should die, 97% chance they should do well. But the hospital down the road, they have a 1% chance of mortality and a 10% morbidity. So there's no hiding of facts, and that is important. Now, education is a lifelong process. We're all learning, no matter how young or how old we are. When we talk about trauma, it's basically a big circle over and over and over again. We measure all the data. We compare. We review, which includes a literature review and a review of the case. We come up with an intervention. I'm waiting for my translator to catch up. Sorry. And then we measure and we remeasure. So every 3 months, every 6 months, every year, we go back and look, did what we intervened on, did it make a difference? If we saw a problem with open fractures and infection, and our intervention 1 year later made absolutely no improvement, excuse me, we need to go back and find a better intervention that solves that problem. So very briefly, what are the core components of the TQIP program at every hospital? All right. So every hospital is compared publicly on the web. You know exactly what our numbers are. You know what our data is. We all enter our data into one national trauma data bank, and it's stored there. We pick the audit filters where we want to make improvements, and you can pick whatever you want. Start little and expand. You don't have to pick life or death. You can pick simple things like unplanned return to the intensive care unit, missed injuries, infections, okay? We have the multidisciplinary trauma peer review. And again, everybody is at the table. We respect the opinion of the trauma nurses, the trauma doctors, the orthopedic doctors, the neurosurgeons, the rehab, the blood banks. Everybody is there to discuss the case and put their 2 cents worth in. it is a confidential peer review because there's a huge concern in the West about being sued. If we open up and talk about our cases openly, is this going to come back to haunt us and we're going to get sued for a bad outcome? So all of these reviews are kept confidential and they cannot be used in court for punishment. The whole idea is to focus on opportunities for improvement. Again, it's not a malicious or malignant process where we're pointing fingers at each other. It's a process of where can we do better? How can we improve? So, my suggestions for TQIP Lite model for Ukraine. First of all, start slow. Don't have to reinvent the wheel. Learn from what has worked in America, Canada, Europe. Review how it's done there. Adjust accordingly to the situation that you have in Ukraine. Focus attention on truly improving the quality of care of the patients. A rigorous database and registry. And then target the low-lying fruit. Pick simple core filters to start with. We have a weekly review at most major trauma centers for morbidity and mortality. You can start out monthly or bi-weekly, whatever, but make sure that everybody's at the table. I would strongly suggest starting this and picking 2 to 4, 3 to 5 hospitals where you have the buy-in of the administration, the support of the hospital and the program to carry out this program successfully. Once this starts rolling, you begin to expand that program across the regions, across the country, and make it a national program. You don't want to bite off more than you can chew. You don't want to try and start programs in hospitals that simply cannot work. Now, we all know that infection, unfortunately, is a rampant problem in Ukraine. Only 30% of the hospitals in Ukraine have a clinical pharmacist that is responsible for antibiotic management in Ukraine in the hospitals. That means 70% of the hospitals don't have anybody that supervises or oversees the management of antibiotics. That 70% of hospitals would be a poor choice to try and implement a TQIP program. You need to go to the hospitals that have the resources to do the care properly. Okay. So, obviously there are huge challenges and adaptations that'll have to be made. You, the healthcare providers of Ukraine, know what your limitations in your system are and how you're going to have to adapt to them. Unfortunately, Ukraine is facing complicated, devastating polytrauma patients. In the talk that I gave a couple days ago about drone warfare, about 50% of patients have 3 different body cavities involved in their injuries. So a high velocity fragment from a dropped drone can enter the neck, go through the chest, the diaphragm, the abdomen, the pelvis, and end up in the lower extremity. So we treat those patients very differently than we would treat other penetrating trauma. They may have a small hole in the neck, but the injuries go all the way through. This will make it difficult to properly care for these patients. pan scanning, CT scan, head, neck, chest, abdomen, pelvis, may be the standard that you need to start with because you don't know where the injuries end. Data protection is very important. While we need to share data between healthcare providers, we have to respect the privacy of the patients. I'm well aware, as we all are, of the very limited resources that we have in Ukraine. We don't have trauma registrars. We don't have trauma-trained nurses. First, we have Alicia sitting here from Chicago. She is an example of a trauma nurse. In our level 1, level 2, even in the level 3 trauma centers, there are nurses who dedicate their entire practice to taking care of trauma patients only. And so their level of knowledge, their level of skill, taking care of that patient population is way higher than a nurse who takes care of a medical patient with a stroke or a diabetic or whatever. And I'm not putting down those patients. But the more you do things, the better, the more you see the same patient population, the better you're going to be at taking care of those patients. There are obviously huge cultural barriers. And I would argue that one thing that this country really can change substantially is the culture of taking care of trauma patients, where there are open discussions and peer review. And as one of our previous speakers spoke, the lowest surgeon in the room or intern should be able to speak up just as much as the senior professor. The nurse should be able to intervene. The therapist should be able to intervene. That's what builds a good quality trauma program. So we'll very briefly go through an example how TQIP works. So patients injured by a drone. The audit filter is a delay in starting antibiotics. The case is reviewed. It undergoes what we call primary, secondary, tertiary review. We identify an opportunity for intervention or improvement. We then take that corrective action, and then over time we track whether that made a difference. Some patients here in 5 days have had 7 different antibiotics. That's how you breed out multi-drug resistant bacteria. That's one of the major contributing factors to multi-drug resistant infections in Ukraine. Polypharmacy. The bacteria are exposed to multiple antibiotics, and what happens? You don't kill the bacteria, you end up breeding out a resistant bacteria. The best antibiotic in the world is a surgical scalpel. Proper debridement and cleaning of all dead necrotic tissue, which is food for bacteria, is the biggest improving factor in minimizing wound infection. All right, beyond trauma. So trauma as a field leads quality improvement in the United States. Quality improvement started with cardiothoracic surgery, but the reality is the gold standard by the American College of Surgeons is the TQIP program. And that has ramifications on other programs in hospitals. So from what we do and practice in trauma, our neurologists have improved stroke care. For example, reducing door to needle time. For the cardiologists, the door to balloon time for putting stents or angioplasty in. For the ICU, by following the what we call the sepsis bundles of care, decreasing ventilator-associated pneumonias. All of this came from the first major program of quality improvement for surgical patients, and that was TQIP, the management of trauma patients. And now it also extends to bariatric surgery, general surgery, to all the different fields. So our roadmap for Ukraine, how are we going to do things better? In the short term, there needs to be a focus on changing the general culture, accepting the fact that there must be a review and dedicated resources to review of all trauma patients. It's a change of culture. Over time, look at what works in other parts of the world and adapt it to what you do in Ukraine. And then in the long term, there needs to be more collaboration, international collaboration, not just people going over and visiting, but true international with Europe and America and Canada in terms of the care of the patients. Quality is possible even in war. We should not use the war as an excuse to not care properly and improve the care of trauma patients. We should see it as an opportunity to lead in the improvement of our traumatized patients. Slava Ukraini, slava heroyam, дякую. I think everybody's asleep. Any questions? Yes. Oh, okay.
What a great presentation. Who owns the repository of trauma data in the U.S.?
So that's a tough question to answer. Technically, it is the American College of Surgeons, which is a private group. The government does not own it. And I think I understand why you're asking that question.
That's exactly what I wanted you to underscore.
Yes.
Government is not involved.
Correct.
It does not own it. All this is done by the American College of Surgeons and the quality assurance people in the college.
Yeah, and that's very important. I did not mention that. But
Right.
yes.
And next, you suggest that, well, first of all, you mentioned that the Ministry of Health wants to establish a trauma registry.
Yes.
It's a great goal, but I think that's going to be maybe in the next couple of decades.
Let me
Maybe
interrupt.
not. Maybe not.
They've started,
Yeah.
but I don't know to what extent.
Yeah.
I'm assuming that it's probably not at a very vigorous level yet.
Yeah. And so your plan is that a hospital or several hospitals should start their own trauma registry is, I think, the best road forward. It's an excellent plan. You need to be the ombudsman or the guy that leads the parade. Every hospital you touch, for them to start their own trauma registry in a very simple, primitive way, and that will build, and then they can coalesce with other like hospitals in the oblast, and hopefully that will then metastasize to other places, and then they can bring it together under some organization, and it may or may not be the Ministry of Health. It may be the Ukraine College of Surgeons, someday in the future. But the important thing is that don't wait for the government to come and tell you what to do. Do it yourself. I think the people that are here have gotten enough information that they're able to do that. And it doesn't take much. It takes the goodwill, the enthusiasm, and gathering like-minded people together to go through with that.
Yeah, I agree with all your points. It takes will and determination to do it. I think putting all that data in the hands of one government is challenging and a problem. It should be kept somewhere in the private sector. It's certainly not easy to do that, but there are people here in doing our courses and such. What I sense is a lot of the younger surgeons really get it and want to do things differently than what has historically been done here. And I think that needle will move forward. It's going to take a long time. Any other questions?
Okay. Oh, go ahead.
Yes.
It's excellent presentation. My question is, we have been here multiple trips here.
Yep.
have you noticed any change in the culture in sense of second look, third look surgery? If a patient needs multi-specialty involvement, do they go in the order of patient need or in the seniority of the team? Thank you.
So that's a tough question to answer. Have I seen a change? Yes, because the whole idea of damage control laparotomy, for those who are not surgeons, basically in the old days, which wasn't that long ago, we would try to fix everything and close the patient at the first sitting. And that results in huge mortality. The reality is there's a tremendous amount of energy related to these blast injuries to military combat. And so what looks healthy and clean and viable at the initial operation will blossom out, mature into necrosis, death, patients closed, they die. I mean, we have pictures of horrible leg wounds that were closed that turned into septic shock, necrosis, etc. Have I seen a change, Chandra? Yes. There has definitely been an appreciation because there was no damage control laparotomy 3 years ago. And that probably realistically contributed to a lot of the mortality of patients that could have been saved. There still is a general cultural, the commander is always right. And it depends who your commander is, whether they agree to do things differently or try and step outside the box versus those who are more skittish and afraid to try things. It's very difficult to change. In America, let me just add one thing. Betadine affects your immune system negatively. So we've stopped putting betadine on open wounds because it dries out the healthy tissue. It increases your risk of infection. In the old days, everybody got betadine. Yes, and in the drains, exactly. I still see betadine on wounds here. And those dressings aren't changed for 2, 3, 4, 5 days. Now, some of that has to do with how many people you have to do dressing changes. So if you're at Mechnikov Hospital and you have 125 patients in your ICU and everybody has a extremity amputation or an open abdomen, it's very difficult to take those patients back every 12, 24 hours for damage control and second and third operation. So there's a practical limit. They don't have the resources. But have I seen a change to the better? Yes. But there's still a lot of opportunity for improvement.
I just want to touch on one other aspect, and that was the confidential peer review system.
Mhm.
So in the States, we have laws that protect that. That's protected and privileged information. That's
Yes.
why we can, in a closed room, we can discuss medical errors and adverse events freely, or we should be able to freely discuss them for the purpose of analyzing it and coming with a solution on how to do things better.
Yes.
Here, I'm not sure there are laws about that protect this information. I just don't know. I can't comment on that. But certainly when it comes to physicians owning up to medical errors and discussing them, whether with the family or with their peers, let's say in the department, there's a lot of reluctance to do that, and they don't like to do that. They do not like to point fingers at themselves that perhaps I did something wrong.
Correct.
And that's a cultural thing that has to change with time, but it also has to be assisted by the proper laws that protect that information.
Yes.
As we have in the States and in Canada.
Yes,
those
I
laws too, so.
completely agree with you. Just so you know, in Florida, where I've practiced for the last 8 to 10 years, it turns out the lawyers can get their hands under the sunshine law of peer review now.
Wow.
That's not good at all.
That's not good at all. Yes, unfortunately. No system is perfect. But yes, there has to be buy-in by the hospital administration, and there has to be buy-in by the government if you're going to push the needle forward.
So I think at this point, I'm going to say thank you. I'm going to thank to all the speakers. I also want to thank to everyone who attended and stayed to the last end. I know it's a really, really long day. I think don't forget to attend the award ceremony for the posters And don't forget to join us for dinner when you can continue having conversations. And I hope this has been helpful. Thank you all.